think this is a nice opportunity for the attendees to really ask questions because you have all the faculty here, and I encourage you guys to ask questions. You have a little microphone there, so why don't you go start asking questions?
There we go. I think it works now. Thanks everybody for the course. Question to all the faculty. I think Dr. Durman showed a picture where he said potentially on CT scan he can see an anterior osteophyte or ventral osteophyte causing the compression. In those situations, many people would consider doing an anterior foraminotomy or a Joe procedure or an artificial disc for that instead of going a posterior endoscopic foraminotomy. Just curious on anybody's decision making on why you'd pick one versus the other in that type of situation.
So in case you guys didn't hear, he said for ventral osteophytes, he says it's probably easier to go for like an anterior-based procedure, even a Jobe. And as to the faculty, anyone jump in? Mark?
Sure, I think you can go any way you want, which you're most comfortable with. I would be cautious about the Jobe procedure in an osteophytic. It's just not really easy to do that procedure, to drill out both directions through an anterior approach. And also, you're really doing a lot of disc work in that perspective, so this saves the disc. And you're right, an anterior cervical arthroplasty works great too. And I think you have to decide which ones you preserve or prefer, and which ones you prefer yourself, or what your outcomes are. The rate of revision for an anterior arthroplasty is 10%, right? If you look at the Australian data. I don't believe that our posterior cervical foraminites have that degree of revision surgery and arthroplasties, a pain in the butt if you've ever done one. So I think there's younger patients, you're gonna pick that poison of how much you're gonna want to live that patient out and be responsible for their arthroplasty and revisions. But that's just 2 points on all the myriad of decisions you might take. I think Ray has a good experience on posterior cervical. Do you have a feeling on that, posterior cervical versus arthroplasty?
So posterior cervical foraminotomy. So I'm a pessimist, and I view the world as if something fails, how am I going to fix it? So posterior cervical foraminotomy, you still have a primary anterior procedure. So whether it's a disc replacement or an ACDF, you still have like one of the best surgeries in the world to address it. If you do an anterior approach, if you do an anterior fusion, typically if you have a reoperation, oftentimes it's the next level. And risks of hoarseness, swallowing difficulties, hematoma, they all kind of go away with the posterior cervical approach. It's just, like Peter was saying, it's an elegant surgery, beautiful anatomy, and it addresses the primary problem. And it's certainly more cost effective as well. This is the other thing that we're finding. So hard to argue against it, actually.
So Sanjay, you always make this really great point. You say that some of this endoscopic procedures really redefine failure. Can you kind of define that?
That's Ray's line.
Yeah. Oh, that was fine. Both you guys. Where?
Well, I'll let him answer that question, but I will make this quick point. They're both motion preserving surgeries, right? Arthroplasty is motion preserving. Endoscopic foraminotomy is motion preserving. One is an implantable device still, right? So avoiding putting a potential, a implantable device with potential hardware complications down the line is avoided when you do a posterior cervical endoscopic foraminotomy. But Ray, take that, redefining failure.
Yeah, I do have a series of patient that I did addressing the ventral pathology through a posterior endoscopic foraminotomy approach to take advantage of the versatility of the endoscope. I do not think just unroof the foramen, that indirect compression is enough, because the osteophyte is still stuck ventrally underneath the nerve root. So I usually go there, chip off the osteophyte with osteotome, that if I can, yeah. Huh?
Addressing the ventral.
I believe you should address the ventral pathology through a posterior. I mean, if you do a posterior approach, motion preserving, there is significant ventral pathology. You cannot leave it.
So for Dr. Shen's point, I think I do sometimes chase. I was talking to Christoph before about chasing ventral stuff. Now, to do that, sometimes I take some of the pedicle down to make it easier. Was that what you do to get the ventral pathology? It is a little bit dicey to do that, but is that what your technique is?
Yeah, you just have to create room before you actually put any pressure on the nerve roots, right? You can either drill part of the pedicle, create room that way, or you can use the osteotome, go to the disc space, create a little bit of space, and then you can use a protected drill proximally or distally, so that way you put a minimal pressure on the nerve roots. So you just have to be careful, especially when you do C4, C5, Yeah.
So, but you also have to keep in mind, if you have a large ventral osteophyte and you're doing a disc replacement and you're having to drill a lot of bone posteriorly, I mean, you're doing a fusion, just so you know.
So one strategy that, like to address the ventral pathology that I find is helpful, I used to use shielded drills, but you can actually use a 3.5 diamond drill bit, just basically drill straight in there until you're kind of covered by the PLL, and then just move the shaft against the nerve root and drill underneath the nerve root. And then you take the upingual micropunch and sort of cut it down. So that seems to be working quite well.
These are the most technically challenging procedures for the posterior cervical foraminotomy. This is not something that, when you decide to pursue these, I'm comfortable drilling underneath the nerve root, but it's not my favorite thing to do. It's not like I'm like, oh, I'm going to choose to do this. But, to Shen's point, that one of the biggest issues is that you're going to be referred posterior cervical foraminotomies because it's a failed ACD. There's a mature fusion up front. There's still persistent bony foraminal stenosis. And you're going to have to decide, can I just get away with the posterior decompression? Do I have to do anterior and posterior decompression for that nerve root to alleviate it? But this is going to be that salvage, maybe, the failure quote and redefining failure. But that is probably one of my most common indications I see for posterior cervical foraminotomy is bad ACD or hypertrophic bone after ACD referred to me for persistent symptoms.
Also, I think we're going to start understanding a little bit better the adhesions around the nerve roots, because if something is dorsally displaced but stuck to that osteophyte with the normal range of motion of the cervical spine, that nerve root could be stuck, right? So sometimes if you don't get the full ventral component, compressive component, but you release that nerve root, it can start freely moving over that. And I don't know how we look at that stuff, but I think we're going to learn that adhesions have a lot to play with nerve irritation.
Yeah, to further your point, if you don't mind, the sport trial, right? 18%, if you looked at people who sport trial for lumbar disc herniations, 18% have reherniation events. But your revision rate's around 5 to 6%, because in these procedures, and particularly open procedures, you're removing all of those adhesions, all of the foraminal suspensory ligaments you're going to remove oftentimes to free up that disc. And you see it all the time. I have patients come back, successful endoscopic discectomy. They can have a reherniation. I have an ER physician who is an amazing power lifter. She keeps herniating disc fragments, and she keeps coming in. I think I herniated the disc again, and you look at the MRI, and you're like, yeah, you have a new disc herniation. She's like, yeah, it doesn't bother me, right? It was the first one that bothered her. It's not the third one.
I think something important about the anterior osteophyte, taking the osteophyte out from the posterior approach is you don't think about it as the vert is there. So, something that when I was in Korea, I never thought of where the vert is when you're going posterior. But if you're doing what Dr. Shen's talking about, just being careful, that the vert is actually really, really close to the ventral nerve root. So I don't know, what your thoughts are about that.
So before we go any further, I think there's more questions.
Yeah, more questions.
For a while.
Just on cervical, always identify the vert. Pre-op imaging, always 100% of the time, whatever you're doing, because you'd be amazed what you find.
And there are loops. There will be loops. I can show you MRIs with loops. You'll watch out.
Look at the MRI. Next question.
Yeah, so I'm interested in hearing from the faculty how much of this endoscopic lumbar surgery you're doing under general anesthesia versus some form of non-general anesthesia.
Why don't we poll the faculty to get the answer? So let's go for awake surgery? Raise your hand if you do mostly awake lumbar surgery. I mean, fine.
Depends on which procedure. Which procedure, and if you can't. Some of us are in academic institutions where it's like the rotating anesthesiologist, and some people are in private practice where they have, you know, a better anesthesia setup where they can have reproducibility with the same anesthesiologist, same techniques, right? I think, Ray, you've got great series with anesthesiologists who are able to maintain a prone sedated patient, and I have to beg on my hands and knees to do prone sedated.
I do majority of my lumbar thoracic cases. If I can, just do with either awake or under just sedation, especially for patient with comorbidities, you know, had a prior stroke or cardiac problem. So whenever I can, I try to do them under local with sedation, even like one-level fusion cases.
So to that point, my follow-up question is, for your older patients that are cardiac patients who are on antiplatelet, anticoagulants, et cetera, et cetera, et cetera, how are you managing the antiplatelet, anticoagulant in your endoscopic practices versus what you used to do, or at least what we've been taught traditionally in open surgery with absolute stop for a month at a time and blah, blah, blah?
You know, one thing is with what we have seen here, we have a lot of, at the University of Washington, we have a lot of patients that are on blood thinners. So certainly I don't operate on patients that are on double sort of antiplatelet therapy, so Plavix and aspirin, that's really too much, but aspirin is no problem typically. You know,
You don't do it at all, or you?
no, I do aspirin, but never aspirin and Plavix together. It's really otherwise difficult for bigger surgeries like Lammy's. It's difficult to stop bleeding intraoperatively. I probably would do a transforaminal if you have to, but you know it's you know, as you have seen on the videos, intraoperative blood control, hemostasis can be challenging, and
Yeah, I think he's just clarifying the question. You would stop the antiplatelets.
Microphone.
You would still,
Microphone.
Yeah, you would still operate, but you would just stop.
Yeah, I would-
Plavix.
yes, I would-
You'd be okay doing aspirin, but you'd stop Plavix.
yeah, I would stop Plavix like a week before, keep my aspirin, and do the surgery.
Suffice to say, the blood control is actually the biggest issue. So you want to be safe with your patients. You want to minimize all of those same elements, but I don't operate beyond an 81 milligram aspirin because I find that like your operative duration prolongs because the bleeding is slightly more.
I actually think it's the opposite. You know, so if someone is on, like you have to operate on them, it's actually easier to get hemostasis open and leave a drain in than doing an endoscopic case. So for me, it's the same as open, but if I have to operate, it's either tubular or open because it's easier to get hemostasis, and you can leave a drain a lot easier than doing it endoscopic. So I don't know, that's my thought.
You can leave a drain endoscopically if you want.
Actually, going back to the worldwide topic of spine surgery. Oh, right. Before you destroy Osama, let me just say that almost all the surgeons in Korea and China leave drains in after endoscopic spine surgery. And I asked a couple Korean surgeons, why are you guys leaving drains in? You don't need to. No one in America does them. And his response was, it's more of a cultural thing. We like to, it just makes us feel better. That's what he said. And then I think, I hope this is not going to be online, but then there's the idea of, this idea of when you leave a drain in, there's something to monitor for a longer hospital stay, because there is some kind of monetary system that happens when your patient stays longer because surgeons own hospitals there, and don't put this on YouTube.
Yeah, they do report longer hospital stays, but right.
So I think we need to be more specific when you ask about, well, what do you do for Plavix? Like, that's a very general question. So, and what do you do for awake surgery? So, well, I'll take each of those. So awake, I do all my transforaminals awake. Thoracic, lumbar, they're all awake. Interlaminars, I will do them awake if they're sick or if it's worth going through the trouble of having like a one-shot epidural. So for decompressions, we'll do a one-shot epidural and some light sedation. Mark will do spinal without sedation. If I'm doing a fusion, I'll do spinal because I need a little more time. In terms of blood thinners, you have them come off the blood thinner the appropriate amount of time that the blood will clot, whatever that is, depending on the blood thinner, right? I start them back up on blood thinners much faster. Like I used to leave them off for a period of time. Now it's basically 24 hours later, I say you can start back up on it. Because if they're still bleeding at that point, they're gonna have a hematoma anyway. So I don't agree with open being less bloody. In fact, I think you have a higher chance for an epidural hematoma the bigger the opening in your epidural space, because you can get a hematoma that compresses a larger volume of dura and thecal sac. So.
Wait, I actually brought some boxing gloves. I'll just.
I agree with you 100%, but I think if you get a bleeder, it's easier to stop with the traditional stuff. That's the reason why, but I agree with you 100%.
Yeah, no, you definitely have, but like, I also do everything I can to make bleeding less of an issue. I put epinephrine in my fluid. I use TXA on everybody. If I'm concerned, I'll put some thrombin in at the end, or we'll squirt flow seal and let it sit. And you want the field dry as possible. I suck out all the fluid before I close the wound. Like I don't put a drain in, but I don't like leave fluid rushing up if it's coming out of the nooks and crannies. I try to suck it out through the scope. So, yeah, I don't think it's anything special beforehand. You get them off the blood thinner appropriate amount of time, which is usually about 5 days for most things. I would err on the side of 7 because I'd rather them be off 2 days too long than 2 days too short. That's my old saying of don't shoot the hostage. You know, if you're gonna get the guy with the hostage, don't miss here, miss here. So don't get it perfect, but miss in the right direction. So.
I do think that your point about treating some of these patients who most people would say, we can't do surgery on you. You're on blood thinners, you're old, this and that. I think endoscopic does open doors. I think their question about the awake surgery, I think like Mark really highlighted, you have to have buy-in from your anesthesiologist. And I've never had luck with my anesthesiologist. So Ray's lucky. He convinced him, maybe it used to be lucky.
Well, so I will say it took some arm twisting to start, but the funny thing is once they saw how quickly the patients got up, so I do all these in the ambulatory surgery center. Once they saw how quickly the patients get up and leave, they were like, oh, let's do them all awake. And that's also sometimes problematic because, you know, we have fellows and residents and it's harder to let them do things when patients awake and
I mean,
going, hey, what's taking so long?
Right. I mean, one thing is like, you know, when you look at very, very efficient centers, you know, especially in Germany and South Korea too, the most efficient centers I've seen actually have general anesthesia because you just put the patient to sleep, do a surgery, move on quickly. So it takes a lot of extra time. Initially, I did much more patients awake, which is difficult at a university because there's a rotating, you know, staff of anesthesia. You know, if it takes a lot of time then to settle down the patient, give them more local field sort of anesthetics. It adds some time, but we have experts like, you know, Albert Telfian does a lot of wake, Ray does a lot of wake, so I think you can definitely set it up.
My music's too vulgar for awake anesthesia, so that's why I don't do it. But
Can we pull I'm just curious on the participants because maybe there's something that's got sent out. I just wanted to see like how many residents are part of the participants?
raise your hand if you're a resident.
Raise your hands. And then fellows?
Raise your hand, fellow.
And then like first 5-year attendings?
Nice.
And then anything after that? Okay.
Nice. Okay.
Shannon raises his hand.
The expert raises.
Yeah.
The master. Is there any
That's
other?
a good spread, huh?
Is there any other questions that you guys have? And if there's no more questions, I'm going to open up to the faculty. Is there anything that you guys think, when you were first learning, that you wish someone told you? Anything? Any words of wisdom for our young surgeons who are trying to embrace endoscopy that you think would really help them?
How much time do we have?
I know.
That's a big one.
Just quick ones because we're going to go to dinner soon.
So one thing, I mean, there's a lot. So one thing, cadaver labs, you're not going to practice how to control bleeding, right? Bleeding is one of the more annoying things of endoscopic spine surgery. Eventually you get used to it and you learn some tricks. There's cases where you try all the tricks in the book 3 times over and it still doesn't work. It can get frustrating amongst the other things of learning endoscopic spine. So, you know, you can get all the stuff down pretty well here in the cadaver lab, but in your first case, that experience is going to be very different from your first 10 cadavers or whatever still, because controlling bleeding when you get into it is inevitable. So that first case, you're going to have to deal with things that you haven't done before in a cadaver. So, going and observing cases to see what the real workflow is like on a live patient, I think is pretty important. So that's one point.
Yeah, I think that's very valuable. I also think my experience, you want to start with very simple indications, very safe indications. L5S1 discs are a very good operation to do, where you don't have to do a lot of bone drilling, et cetera, when you're first starting. Then you can get used to manipulating the scope. Then actually, the one thing I would have told myself years ago is start drilling a lot more early and learn how to drill, because you can expand your indications a lot faster. So it's kind of counterintuitive, but you actually develop that skill, even though you might not need it for all the cases that you're doing early on, so that you can expand your indications faster.
I would just add that when you're starting off, rely on more x-rays, because it's so easy to get lost. You won't know where you are. So just get an x-ray and get a picture, see where you're at. That'll help you a lot.
So I just wanted to add, I think something along the lines of what Sanjay was saying. When I was at the University of Miami, I only had 10 weeks with Mike Wang. When I was a fellow, that's the way the fellowship was structured. And so there's only so much you can learn in 10 weeks, right? And the rest of it, I think you have to rely on these labs, asking questions, learning from other people. I've learned a lot of what I know from a lot of these other faculty. But I think the thing that was most difficult, like especially for transforaminal surgery, is that once you can get there, we'll teach you how to get there. But once you get there in a real pathology situation, it's actually kind of hard to describe what you're supposed to do step by step, right? And so if you can spend some time traveling to see somebody actually do cases, I think that's what would have gotten me through my learning curve a little bit better.
Yeah, I couldn't agree with you more. I started out with picking out what I would say bread and butter sort of vanilla cases, stenosis cases early on, and those were a challenge climb for somebody that early on, and you kind of got through it by length of duration of surgery. And then as I spent more and more time doing endoscopic procedures, I wanted to go see who else was doing it, and I wanted to go travel somewhere else and see somebody else. And then you're like, oh, well, that's cool. I'm pick up a little favor. So if you can do that early rather than late, you would totally make things a lot easier, because all of us have like a bag of tricks that you've picked up over the years, and everyone's got a little bit unique flavor of how they do things. And if you had time, that would be awesome.
And to that point, I would say, with the endoscope, you have a camera, and you can hit record, and then you can go back and review the tape. So if you're doing, a case with an expert surgeon, right, mimic what they do, see what they do, kind of review the imaging, review the tape, and talk to them about their indications, and then from there learn what they did to achieve the goals of surgery. I don't think there's any, better way to be self-critical than to go back and review the tape and review the actual surgery and see what you could have done differently, or what you learned that you did well and worked well for that patient.
And to piggyback on both your guys' points, you guys are all here. We're going to be in the lab tomorrow, and you have some world-class experts. I mean, some guys here, it's your opportunity to pick their brains. So what I would highly recommend is, yes, if you're in a lab, you're at one station, if you feel like you got a little bit out of that, walk around and see all the faculty and ask questions. Because when they're on the cadaver, you can learn quite a bit, and just write some notes down, because I think then you can even get contacts from some of us and then ask us questions later. I think we're all the faculty here want to see endoscopic spine surgery not remain 1% to 3% of the US surgeons. We want to see it become part of spine surgery. So utilize us. Okay. All right, thank you, everyone.